A very good afternoon to all of you. I am Dr. Ashish Khanijo, a cardiac surgeon and a transplant surgeon from Pune, Maharashtra, India. I'm talking to Dr. Ono, who has come down all the way from Tokyo. He works in the Tokyo University Hospital as professor and head of the Department of Cardiac Surgery. And I will be talking to Dr. Ono as regards the INTERMACS scoring system. Very good afternoon, Dr. Ono. This is our very first meeting, and I would like you to talk on the INTERMACS scoring system. Would you please elaborate a little bit on that?
Okay, good afternoon, everybody. Thank you for inviting me to this TV lecturing session. I'm very happy to answer your question. As we may know, the full classification of the severity of heart failure, New York Heart Association functional class has been used for a long time, and 1 through 4. Also, ACC, AHA guidelines for definition of severity of heart failure stage A, B, C, D. This is routinely used to classify the mainly on the outpatient clinic basis. And once the patient falls into the stage D, NIHF4, we may need to have to take a look at the patient condition more closely. And especially that is true for the patient who requires ventricular assist device treatment. So initially in 2006 in the United States, surgeons and cardiologists come together and to talk over what the classification is appropriate to find out, to treat, and to follow up this type of severely ill patient.
True.
So they reached new classification called as INTERMACS. INTERMACS is a kind of acronym which means interagency classification for mechanical circulatory support, as you may know. So there are 7 grades in the INTERMACS classification. Can I continue my talk?
Yeah, so when do you feel is a good time for a patient to be selected for INTERMACS scoring, and then whenever you feel it's a good time to put them on mechanical circulatory support?
Okay, so there are 7 grades in the INTERMACS classification, and the upper 5 or 6 grades is within the range of NYHA class 4. So what grade is the best situation for which we need to think about the initiation of mechanical circulatory support treatment? For bridge transplantation, the most common stage of INTERMACS is the class 3.
Which is what I meant. Like, do you have the revised classification system for Asian population, or you do have specific kind of guidelines for the Asian population?
Right. Yes.
If you can elaborate on that.
Right. Yes. And there are so many reports from the United States, from Europe, and what situation, what INTERMACS classification patients are most appropriate for the initiation of ventricular assist device treatment. Probably as mainly class 2 and class 3. But for Asian countries, is there any difference? Some part yes, some part no. The most appropriate timing to think about starting mechanical circulatory support is INTERMACS class 3, because the patient is stable on the continuous infusion of inotrope. Their end organ is well maintained in function. So at the time, bad implantation surgery itself imposes serious damage to the patient body as well as other organs. So the patient needs to be stable at the time of implant, then the result is better.
Even in a place like Tokyo, with your kind of center, with your kind of university medical center, we'll find how many of these patients you think, what percentage of cardiac patients you feel go on mechanical circulatory support, and of what kinds of support?
Okay. Okay. And our center has the Advanced Heart Failure Center. So we have more than 30 beds for all the treatment only for
that's a big number.
Big number of hospitals. So we have a lot of referrals from outside hospitals.
Okay.
And the patient at the stage at the time of referral is various. It's, some patients are referred in a cardiogenic shock status. In this situation, it's quite hard to implant continuous flow VAD safely. So for that type of patient, we may need ECMO or paracorporeal VAD, or in a selected situation, impeller. It's from femoral artery or axillary artery. So we may need to find out what the best MC is by looking at the patient condition and organ function, or how the patient's circulatory status is.
Vis-a-vis the bridge to transplantation or even destination therapy, do you think these guidelines can vary, or there could be certain amount of modulation towards the guidelines?
Yes.
Do we need to speak about that as well?
Yes, sure. And for bridge to transplantation, regularly patient age is younger, and organ function are not so damaged in the majority of patients. So, but destination therapy, patient age higher, the majority of patients are having this type of low perfusion status that may have some sort of damage to the liver and a kidney or lung. So these end organs are partly damaged. So if we want to proceed to implant of continuous flow VAD for DT purpose, the patient's hemodynamic condition should be stabler than that of a BDT indication.
All right. What percentage of patients you feel are more likely to go towards heart transplantation or even heart-lung transplantation, and what percentage of these patients would stay back with a destination therapy?
Oh, okay. That depends on what type of patients you have as a referral. Let me talk my experience.
Sure.
And our center is our largest heart transplant center, also the largest center for implanted continuous flow VAD in Japan.
Okay. So
the majority of patients are referred for bridge to transplantation, and also some patients may have a kind of associated lung damage. So the percentage of requirement of heart-lung simultaneous transplantation is low. Fortunately, less than 5%.
Sure.
The majority of patients are indicated to bridge to transplantation. We have a strict age limitation to enroll the patient to heart transplantation. That is 64 years old.
All right.
So if once the patient age is over 65, the only indication for this type of patient is destination therapy, or the patient has a short history after the malignancy surgery, like a gastrectomy, a colectomy, or breast cancer, or thyroid cancer. Usually 5 years are required to be free from the cancer recurrence after the surgery. If the history after the cancer surgery is less than 5 years, we may need to think about destination therapy.
All right. Do you wish to speak about the results of these kind of mechanical support systems, or vis-a-vis the kind of guidelines that we are following for the patient population?
Okay. Yeah, sure. And as you know, according to the INTERMACS report, and the 1-year survival rate is nearly 80%. By every year, 10% survival decline.
Okay.
In Japan, fortunately, we have a little bit better implant results. We have JMAC system. JMAC system is a kind of registry classification that is similar to INTERMACS in United States. According to the JMAC report, 1-year results for BTT patient is 92%.
Which is great.
Yeah, and the
Really?
2-year is 87%.
That's good.
So far.
Really, yeah. So we have been listening to various kind of mechanical support devices since morning. So considering all that, where do you see the future is going to be? Is it going to stay back only as the RVADs or LVADs or BiVADs, or it's going to go towards the mechanical hearts or total artificial hearts? What do you see towards that?
Yeah, that is a very good question. So that is a question on which everybody wants to know.
Yeah, sure.
So as you know, the miniaturization of the device allows us to implant this device to a small body size patients, like a small body size lady or children. They may greatly change our clinical practice. Until recently, the body size restriction, we have a strict body size restriction for the implanting continuous flow bed. Now we have a small size of continuous flow bed, and also the large-scale study showed us safer long-term results, less complications. That may change our practice greatly. So we may talk to the patient in a kind of easier way. Oh, this is okay. This device has less complication and can give you a long surviving chance. So this type of change gives us more chance to approach a patient with advanced heart failure. But in terms of a patient with right side heart failure, still we may need to think about addition of right ventricular support. So yeah, but unfortunately we don't have any specific device to support right side of the heart. So there may be depending upon the engineer's research to find out specific support algorithm or a specific shape of the device to accommodate with right side heart. And also another choice for us to use a total artificial heart to support both ventricles.
Yes.
So now the smaller size of total artificial heart is available. Is a Syncardia 50 cc pump that may be fit well to us, many Asian people with small regular body size patient. So, but we don't have many experiences of implanting Syncardia total artificial heart in Asian countries. So we have to accumulate our clinical experience more to say something how to effectively safely implant this type of device in Asian population.
Sure. Just one more question that I would ask is, in addition to the, well, we have been seeing INTERMACS scoring from 2006 through 2015 to now 2019 guidelines. Would you comment anything on it that can probably be added or subtracted from the present guidelines to make it more effective, more selective, and more efficient?
Yes, and as you may know, the roadmap study was done 4 or 5 years ago.
Yes.
At that time, the stabler, lower level of INTERMACS patient might be effectively treated by insertion of continuous flow bed. Just by looking at the survival curve,
Yes.
and that patients enjoyed a better life. But adding the complication, that patient had much more complication rates.
Okay.
So that hindered the U.S. surgeon to start continuous flow bed in these low level of INTERMACS patients. But now the smaller devices available with less complication rate. So maybe the lesser degree of INTERMACS level may be better for both bridge to transplantation and destination therapy. So probably INTERMACS 4 or 3 is the best timing to think about the bridge to transplantation, and INTERMACS 4 and 5 or lower maybe the best timing to talk to the patient on the chance of destination therapy implantation.
Great. Well, just before we wind up, one funny question. As in how we see that the newer and newer devices keep getting smaller and smaller in size, the battery sizes keep going bigger and bigger. Would the advanced countries and technologically advanced countries like yours definitely look at reducing the size of these batteries and prolongation of the timing of the change of batteries? Would that not be possible?
Yeah, I want to believe so.
Yep.
So it depends on the engineers, technical innovations, not
Yes.
not our effort. But I believe the engineers, India, Japan, United States, Europe, altogether, these are kind of updated engineering will improve more compact and battery with a longer life.
All right, sure. Thank you very much,
Thank
Dr.
you very
Ono.
much.
I think that should be all at the moment. This was really pleasant to interact with you here, and I hope you enjoy your stay here at the conference venue and in Delhi.
Thank you very much for
Thanks
inviting
very
me.
much.
Thank you.
Thanks a lot.